The Dragon 1 study is really the first study showing that for patients with peritoneal metastasis, that administration of IP chemotherapy or intraperitoneal chemotherapy can potentially lead to a survival advantage. Now, what we really don't know is what's that broader applicability to non-Asian patients, and then also what it might have an effect in terms of with more modernized regimens. The regimens that was used in the Dragon study were, somewhat more, I would say, a little bit outdated, systemic treatment regimens. And I think with more modern day systemic treatment regimens, we have to do additional analysis to see whether or not intraperitoneal chemotherapy has a role in this patient population. I think for HCC, I think the challenge has really been in the adjuvant setting. We don't really have FDA-approved adjuvant treatment, and we certainly have seen some recent failures, such as the study of IMbrave 050 with atezolizumab plus bevacizumab failing to meet its primary endpoint after longer-term follow-up. So I think, with this novel type of CIK immunotherapy, I think the results, at least from the institutions in Korea, was reassuring. But we need to do more larger global studies to see whether or not this would be a potential adjuvant therapy option for our patients moving forward on a global level. And I think in the locally advanced setting, the CARES study just tells us a little bit what we know from other locally advanced studies that was presented previously, such as the EMERALD-1 study, as well as the LEAP-002 study, that the combination of TACE plus combination immunotherapy does have a role in locally advanced HCC, but it's really dissecting what was the true population. The CARES study took a more advanced patient population. If you actually compare it to historical controls with systemic therapy, there was really not much of a difference. Yes, it was much better than TACE, but would that have been a similar difference compared to just using systemic therapy in a much more advanced patient population? I think the StarterNet study was really an initial stepping point in terms of looking at combination frontline therapy with the agents that we have for neuroendocrine tumors. So with everolimus, in addition to lanreotide, we know that there will be added toxicity, particularly hyperglycemia, some mucositis, diarrhea with the everolimus. That's a trade-off in terms of for additional progression-free survival advantage, especially in a higher risk population. So those that might have a slightly higher Ki-67 proliferation index, or those that have more significant liver burden that was included in the StarterNet study. I think what's really missing is and ultimately the study that really needs to be done is can we do a study comparing everolimus plus lanreotide versus lanreotide? Because that's really what we're doing as first-line treatment for a majority of our patients with well-differentiated neuroendocrine tumors. And then that will really tell you what is the additional toxicity with combination therapy versus our frontline regimen with just lanreotide right now, which we know typically does not have much toxicity at all for our patients.